Well, welcome to the Malnutrition, Sarcopenic, Obesity. I'm Gina. I'm with the Cancer Center. It's my pleasure to introduce Andrea Peters. She's a clinical dietitian here at the hospital, and we're happy to have her. She is super knowledgeable in this area and this topic. So, welcome.
Thank you for joining me for this webinar today. In my time as a dietitian, I found that I really do learn the most from collaborating and discussing with my colleagues. So I will be asking a couple of questions during this presentation just to encourage some discussion. Let's jump into nutrition considerations in sarcopenia and malnutrition. So first, we'll go through our objectives. We want to define malnutrition, sarcopenia, and sarcopenic obesity, review the prevalence of each condition, examine findings on these diagnoses, and discuss potential nutrition interventions to prevent or treat these conditions. So we'll go ahead and start with malnutrition. The World Health Organization defines malnutrition as deficiencies, excesses, or imbalances in a person's intake of energy and/or nutrients. Aspen also has a definition for malnutrition that varies a little bit. They define it as an acute, subacute, or chronic state of nutrition in which a combination of varying degrees of overnutrition or undernutrition with or without inflammatory activity have led to a change in body composition and diminished function. So notice that both of these definitions mention excesses or overnutrition. That's because malnutrition can absolutely and often does exist in overweight and obese patients, which is key in our discussion today. There was a study published in 2020 in the Journal of the American College of Cardiology. This study included 6,000 patients with acute coronary syndrome, and it was noted that between 8.4 and 36.7% of patients with a BMI greater than or equal to 25, so overweight or obese, were moderately or severely malnourished, which I think is pretty significant. Overweight and obese patients are often overlooked when malnutrition is concerned. Throughout my career, I've often heard things like, oh, no nutrition for a few days will be good for them when talking about an overweight or obese patient, when really it can be detrimental to their health and overall survival. So here are a couple statistics on malnutrition. 20 to 50% of inpatients meet criteria for a diagnosis of malnutrition. However, we know that the actual prevalence is likely higher because malnutrition is very often underreported and typically underdiagnosed as well. Up to 50% of elderly patients are hospitalized due to complications related to malnutrition. These situations, we often see sarcopenia as well, and we'll talk about that in a little bit. Malnutrition is associated with an increase in infections, longer hospital stays, increase in sickness and mortality rates, and overall poorer health outcomes. In the United States, the cost of disease-associated malnutrition is estimated to be about $150 billion per year. So how do we screen for malnutrition? There are several validated tools out there that are used, and a few of those are listed here. The one that I am most familiar with is the malnutrition screening tool, or the MST. I believe that 3 of the major health systems in the Omaha metro area use this screening tool for inpatients. It is a requirement for hospitals to have some kind of screening tool in place for malnutrition when a patient is admitted to the hospital. However, there's no requirement for patients in the outpatient setting to be screened for malnutrition. And I think this is a huge gap in nutrition care in this country. So earlier this month, Aspen actually released a practice tool for risk screening in the adult oncology outpatient population. They stated in this practice tool that malnutrition impacts 25 to 75% of oncology patients. And malnutrition in this population leads to an increase in treatment related complications as well as hospital admissions while they're receiving treatment. Only 53% of cancer centers screen for malnutrition, and just 35% use a validated tool for that screening. So, the recommendations given from this practice tool include that all patients should undergo malnutrition screening in the outpatient setting. It should be done routinely, so after diagnosis and then throughout their treatment. And if the patient is found to be at risk, a registered dietitian should be consulted, assess the patient, and follow them through their treatment and potentially beyond. They also recommended that at least one of 6 valid tools be used. So I mentioned the MST being used in the inpatient setting earlier. That one is also a valid tool for this outpatient adult oncology population. So the outpatient oncology practice that I work with, we recently implemented a screening tool. So we're actually using 2 of them. The patient will first answer the MST questions about recent unintentional weight loss, the amount of weight loss, and any decrease in appetite. If they're found to be at risk, then they will fill out the PG-SGA short form, and that will give us more information before we then do our first consult visit with them. So our consults have definitely increased since starting this screening process, but that means that we're catching more patients, and that's the whole point of these screening tools. So there are a couple of approaches to diagnosing malnutrition. Most of us, especially dietitians, are likely pretty familiar with the Subjective Global Assessment and the Academy Aspen Indicators of Malnutrition, or AIM. There's also the Global Leadership Initiative on Malnutrition, or GLIM. It's congruent with established approaches like the SGA and the AIM. It may be used in combination with other approaches. It just kind of depends on the region and the preference in that area. And similar to the AIM, it includes phenotypic and etiologic criteria. So I'm going to ask my first question for the audience here. And this one is probably mostly for dietitians. What do you see as the biggest barrier to diagnosing malnutrition in the inpatient setting or in the outpatient setting? Okay, so then moving into the different procedures for diagnosing malnutrition, the AIM criteria was first published in 2012. It starts with identifying nutrition risk. Typically, we'll see a loss of body mass, or the patient or family will report decreased oral intake. From there, we move into presence of inflammation. So if there's no inflammation present, malnutrition risk related, such as anorexia, maybe food insecurity. If mild or moderate inflammation is present, malnutrition is likely related to a chronic disease or condition, organ failure, malignancies, sarcopenic obesity, which we'll talk about in a little bit. And then if severe inflammation is present, malnutrition risk is likely related to an acute disease or injury, such as severe infection, sepsis, burns, maybe a head injury. So again, this was published in 2012, and this table gets pretty specific about the percent intake and weight loss in a certain time frame, but these are the different criteria that AIM uses for diagnosing malnutrition in the different categories: acute, chronic, or the social environmental. And it gets very specific as far as the amounts of intake and weight loss in a certain time frame. Toward the bottom of the chart, you'll see some physical characteristics. A dietitian will complete a nutrition-focused physical exam, or NFPE, and use findings from that to support a malnutrition diagnosis. This can be done both inpatient and outpatient. So you see at the bottom, the patient must meet at least two criteria. It doesn't matter which ones, they just have to meet two in their specific category in order for malnutrition to be diagnosed using this procedure. So when I was first an intern and practicing as a dietitian, NFPEs weren't a thing. I wasn't trained on those initially. I think it was in my second year practicing independently that I was trained in NFPE. And this was a big change for a lot of dietitians. Prior to this, dietitians really weren't physically hands on with patients. So it kind of pushed people outside of their comfort zones in a way. But diagnosing malnutrition is important not only for patient care, but for reimbursement. On the inpatient side, malnutrition diagnosis contributes to the reimbursement that hospitals get back from CMS. On the outpatient side, malnutrition diagnosis can't be specifically coded for a diagnosis that's reimbursed, but it can provide evidence and support for a higher acuity patient in the outpatient setting, which can then increase the reimbursement. So, investigating malnutrition criteria, including completing an NFPE, should be done both inpatient and outpatient because diagnosing malnutrition in both settings is very important. Now we'll look at the GLIM procedure. It's pretty similar to the AIM procedure, starting with risk screening using a valid tool, then moving into diagnostic assessment using both phenotypic and etiologic criteria, then moving into diagnosis. And to meet criteria for diagnosis, the patient needs to meet at least one phenotypic criterion and one etiologic criterion. That's a little bit different than the AIM procedure. From diagnosis, we then move into severity grading, which is determined by the phenotypic criteria. So one part of GLIM that is not part of AIM is assessing BMI and using that in the diagnosis of malnutrition. If maybe weight history isn't clear or available, maybe the patient can't provide it. So I think that's kind of interesting. The table on this slide is an overview of the different criteria in GLIM. And again, the severity of malnutrition is determined by those phenotypic criteria on the left-hand side of that table. I do think it's interesting that there's different criteria for BMI in patients in Asia. And this is likely because people of Asian descent often are smaller framed than compared to other areas of the world. I want you to notice that neither procedure, AIM nor GLIM, includes albumin or prealbumin as criteria for diagnosing malnutrition. So albumin and prealbumin are negative acute phase proteins. This means that in times of acute or chronic stress or inflammation, lower amounts of albumin and prealbumin are made by the body, and the body prioritizes making those positive acute phase proteins like CRP. Albumin and prealbumin are more accurately used as markers of inflammation, so they can still be used when investigating malnutrition since inflammation is included in both the AIM and GLIM procedures. Inflammation gives direction in the AIM procedure when deciding if that malnutrition risk is acute, chronic, or social environmental related. So now we'll talk about some complications in malnutrition. So decreased muscle function, particularly decreasing cardiorespiratory function. The best example I have of this is patients who have COPD. So because of their disease, they work harder at baseline to breathe, which causes them to burn more calories at baseline. And then as their disease progresses, they typically experience increased work of breathing when eating, which then leads them to avoid eating or they don't maybe eat as much. And then they get into a state where they're calorie deficient. which then often leads to weight loss, loss of lean body mass, and malnutrition. And then that malnutrition further decreases cardiorespiratory function. So it can be a really vicious cycle in this type of patient. Changes in GI function are seen in malnourished patients, micronutrient and electrolyte deficiencies. Often we think about thiamine deficiency in this population, as well as refeeding syndrome. We'll talk a little bit more in detail about that later. We see decreased immune function, poor wound healing, and psychosocial effects. If you think about it, malnourished patients often don't have the energy to do as many things because they're just physically and mentally more difficult to achieve, which leads them to not do things, leading them to further anxiety, depression, and maybe self-neglect. So again, kind of a vicious cycle when you think about psychosocial effects of malnutrition. Now moving into sarcopenia. There are several different definitions for sarcopenia. The NIH defines it as progressive and generalized loss of skeletal muscle mass and strength. And then Aspen defines it as the progressive loss of skeletal muscle that comes with aging. Note that this second definition includes aging as part of sarcopenia. But it's important to note that sarcopenia can exist at any age. It's just more common in older adults because of normal physiological changes with aging. Just last year in 2024, sarcopenia was added as a diagnosis in the International Dietetics and Nutrition Terminology. This means that when a dietitian is assessing a patient using the nutrition care process, they can select sarcopenia as the problem when writing their PES or problem etiology signs and symptoms statement in their documentation. So I want to go over a couple more definitions. We often see sarcopenia coexist with frailty, cachexia, and malnutrition. We already talked about malnutrition, so I want to just spend a second on frailty and cachexia. Frailty is defined as multi-system dysregulation characterized by weakness, slowness, low physical activity, exhaustion, and weight loss. And cachexia is defined as a multifactorial syndrome characterized by, again, progressive weight loss, reduction of muscle quantity and quality, fatigue, anorexia, and increased inflammatory response. So the two terms are pretty similar and they're often found along with sarcopenia as well as malnutrition. So here's some history on sarcopenia. It wasn't until 1988 that the term was actually introduced. And then the term sarcopenic obesity wasn't introduced until 2004, so 16 years later. In 2010, research noted that subjects with low muscle mass also had low muscle function. In 2016, the medical diagnosis code for sarcopenia was introduced. In 2019, there was a European consensus written on the diagnosis and definition of sarcopenia, and they noted that sarcopenia is associated with low muscle quantity and quality, and they also categorized sarcopenia as a muscle failure disease. Also in 2019, the Society on Sarcopenia, Cachexia, and Wasting Disorders established some diagnostic tools for sarcopenia. Those include a rapid screen and grip strength or chair stand DEXA, as well as ultrasound and creatine dilution. And then just last year in 2024, the Global Leadership Initiative on Sarcopenia was established. So we have GLIM, which focuses on malnutrition, and now we also have GLIS, which focuses on sarcopenia. So sarcopenia, for the most part, is studied in the older adult population. So here's just a couple statistics. 5 of 13% of adults age 60 to 70 have sarcopenia, and 11 to 50% of adults age 80 plus have been diagnosed with sarcopenia. So you can see on the left-hand side of each image on this slide that healthy arm and leg muscle development is pictured, with diminished muscle muscles noted on the right of each image. So this demonstrates the shift from healthy muscle to sarcopenia. Some symptoms of sarcopenia include loss of stamina, difficulty with ADLs, poor balance and more frequent falls, slower walking and difficulty climbing stairs, and as we can see in the pictures, decreased muscle size. There are several risk factors for sarcopenia, but age is the biggest and most common one due to natural changes in the human body that occur with aging. So we see changes in hormones and body composition, muscle atrophy, as well as accumulation of adipose tissue, muscle fibers being replaced with intramuscular fat and connective tissue. We see oxidative stress and degeneration of neuromuscular junctions. There are changes in muscle metabolism, and all of this causes a shift in muscle fiber type and distribution. These changes then all leading to loss of motor units, muscle fibers, and muscle mass. So the image on this slide shows the change in a quadricep muscle from age 35 to 55 and then to 85. So pretty significant loss of muscle mass there. Here are a few more risk factors for sarcopenia. Certain diseases, we often hear the term like cancer cachexia, and sarcopenia is typically present in these patients as well, along with patients with other diseases that have inflammation associated with them, such as organ failure. And in inactivity, physical inactivity, sedentary behavior, this often occurs with aging, but in the United States, unfortunately, we're seeing it become more common across all age groups. And the image on this slide shows the shift from normal active muscle and then the shift into muscle with fewer cells due to inactivity. So we're seeing some muscle atrophy there. And then from there, loss of muscle cells can occur further, which ultimately leads to sarcopenia. And again, malnutrition is absolutely associated with sarcopenia. It includes both under and over nutrition, and it can be related to the impact of medications on appetite. So this often does occur in older adults or people who are trying to manage multiple chronic conditions and require more medications for management of those. So sarcopenia investigation typically starts with self-reported symptoms, and then a physician may give the patient the SARC-F questionnaire. That asks questions about strength, needing assistance with walking or rising from a chair, climbing stairs, as well as falls. If the score of the SARC-F is greater than or equal to 4, then more testing is warranted. That testing can include muscle strength testing, such as the chair stand test, the SPPB, the tug test, and the walking speed test. And muscle mass imaging may be done as well. That could be a DEXA scan or BIA. So there are some serious consequences to sarcopenia. This table does a good job of summing those up. You can see here as the percentage of lean body mass lost increases, so does the severity of complications as well as the percent associated mortality. I mentioned earlier that malnutrition can become a vicious cycle with COPD patients because of the loss of cardiac and respiratory muscle. The same thing goes for patients who have lost a large percentage of their lean body mass who are sarcopenic. So they're likely malnourished as well as sarcopenic and more susceptible to infections, including pneumonia. And when a patient gets into that, 30 to 40% loss of lean body mass category, they can often succumb to the pneumonia. I spent the first 11 years of my career working in ICU, and this is something that unfortunately I saw pretty frequently in my time working on that unit. So now we'll move into sarcopenic obesity. So I think first it's important to define obesity. That is abnormal or excessive fat accumulation that presents a risk to health. According to the World Health Organization, about 890 million adults globally are obese, and 37 million children under 5 globally are obese. So, I have a question for the audience before I continue on with this. So, please participate if you can. So, what percentage of the patients that you see do you think are overweight and obese? And then from there, if you're not a dietitian, how often do you think about nutrition adequacy or potential malnutrition in these patients? If you are a dietitian, how do you advocate for nutrition in these patients, especially if you're concerned about malnutrition? So please just chime in if you have a microphone or type something in the chat box.
I'll say, Andrea, this is Gina. In the oncology world, sometimes there seems to be a little bias or hesitation to put in a feeding tube on this type of patient, even though we know that they're really going to struggle to eat with their treatment. There's this kind of mentality to continue to let them, like, let's see how much they can lose before we do this.
Right.
Mm-hmm.
So then on this slide, we are also defining sarcopenic obesity. So that's a clinical and functional condition characterized by the coexistence of obesity, which we just defined, and sarcopenia. So we know that's defined as low skeletal muscle mass. So a little bit of history and statistics on sarcopenic obesity. I mentioned earlier the term wasn't actually introduced until 2004, so just about 20 years ago. It's estimated that over 40% of US adults are obese, so that's a BMI over 30. It's estimated that 3 to 20% of US adults have sarcopenic obesity, and research has found that the prevalence varies depending on age, gender, and race. And research has also found global prevalence of sarcopenic obesity to be about 11% of elderly people. So, as I mentioned, sarcopenia is often overlooked in the obese population. A lot of healthcare providers just assume that because a patient has excess adipose tissue or body weight, that must mean they're well nourished and they can go longer without inadequate nutrition. It is a pretty unfortunate assumption that puts obese patients at a disadvantage. There has been a lot of research done that's shown that obese patients get worse health care due to bias or being hesitant to seek out medical care because of that bias. So I think we have the opportunity as dietitians, nurses, other healthcare professionals to break that cycle and have those tough conversations with physicians to encourage better healthcare for this patient population. I remember during the white coat ceremony in my dietetic internship, I took an oath, and part of that oath was to provide evidence based recommendations without bias or discrimination. I know a lot of other healthcare professionals take similar oaths, and I think it's important to remember those oaths when we're taking care of our patients, and especially when we're caring for those who may experience more bias than others. So here are a couple of complications we see in sarcopenic obesity. A morbidity rate of 23% in individuals age 75 and over. We know that sarcopenic obesity is associated with frailty, falls, disability, and increased morbidity and mortality. So I want to take a minute again to define frailty. We talked about that a little bit earlier. Here in this definition, it includes the word vulnerability. And I think it's, again, important for us as healthcare providers to really, really advocate for these more vulnerable patients because they may not be advocating for themselves. So I think we we have a duty to those patients. So now we'll talk about some nutrition interventions for all of these conditions. So in malnutrition, a dietitian should be consulted, and they'll start with an assessment. They will assess calorie and protein needs based on standardized equations, or if available, indirect calorimetry is considered the gold standard. Typically in these patients, we'll see high protein needs and higher calorie needs. So maybe up to 2 grams per kilogram per day of protein, assuming that the patient has a normal or low BMI. And for calories, maybe 25 to 35 calories per kilogram per day, again, assuming normal or low BMI. The needs are potentially higher though. So we can use, indirect calorimetry and standardized equations, but clinical judgment is always a huge piece in this assessment of patients. So from there, we will recommend interventions and monitor our interventions. We'll look at, weight trend and percent oral intake. We often will, over time, especially if we're following outpatient, need to adjust estimations of these needs and then provide further guidance as needed. It is important to slowly reintroduce nutrition in this population in order to prevent refeeding syndrome. So small, frequent meals and snacks are often effective when patients don't have a very good appetite. Using oral nutrition supplements, food fortification, and home delivered or congregate meals, like Meals on Wheels, is something in the Omaha area. We do need to keep in mind, though, that even if a patient isn't receiving enteral or parenteral nutrition, a malnourished patient is always at risk for refeeding syndrome. It can happen when a patient is eating orally. And in my career, I've seen it happen most often when a patient has been food insecure. So they've had a good appetite, they just haven't had the access to food. Maybe they're financially insecure as well. So when compared to a patient who's just had a poor appetite, they are more likely to eat a lot more quickly, but that can cause issues with refeeding syndrome. So they need to be monitored closely. A couple more interventions. So once a patient is eating better and approaching adequacy of oral intake, discussing adjusting dietary patterns to improve their microbiome is recommended. So talking about a Mediterranean diet, which also includes increasing dietary fiber intake. And then if the patient is unlikely or unable to take in adequate oral nutrition, nutrition support should be considered. So we always want to use the gut first when using nutrition support. Not only is it more physiologically sound for a patient, rather than giving them TPN, but enteral nutrition plays a huge role in supporting the immune system. And that is particularly important in malnourished patients who have decreased immune function. We absolutely need to be including the patient and their family in these discussions, and the patient's goals of care should be prioritized. I've had probably hundreds of these discussions with patients during my time in inpatient care, and they're really tough conversations to have. I, as much as I can, try to include the care teams, so physicians, maybe the speech therapist, the bedside nurse, especially if they've taken care of the patient a lot and they have good rapport with them. I think a team approach to these conversations can be really beneficial. And as I mentioned earlier, we need to monitor all malnourished patients for refeeding syndrome. So in 2020, Aspen released some consensus recommendations for refeeding syndrome. It mainly looks at monitoring for signs and symptoms of electrolyte abnormalities because those can be pretty severe. In particular, we're looking at potassium, magnesium, and phosphorus, and then also signs of thiamine deficiency and sodium retention. So this table is pulled from those refeeding syndrome consensus guidelines, and it is kind of an overview of signs and symptoms of the different abnormalities that can occur in refeeding syndrome. So hypophosphatemia, hypokalemia, hypomagnesemia, thiamine deficiency, and sodium retention. So these are a lot of words, but notice that a lot of these conditions overlap. So something that may be a symptom of hypophosphatemia can also be a symptom of hypomagnesemia. So that's why it's important to keep close tabs on those labs. And the refeeding syndrome consensus recommendations, they go over all of that. They're an awesome resource. I mentioned earlier that malnutrition can absolutely exist in obese patients. And I think the worst case of refeeding syndrome I ever saw was actually in an obese patient, and it was pretty early in my career. I remember he was in his mid 50s and he hadn't had nutrition for 10 days due to a bowel obstruction. No matter how hard I pushed, the physician just said, "Oh no, he's fine, he's fine." You know, that kind of obesity bias that's there. Um, and then finally on day 10, they let me start him on a little bit of TPN. So even with just, 100 grams of dextrose in his first bag of TPN and a phosphorus replacement before he started TPN, his phos dropped from 1.9 to 0.3 in one day. And he had to be moved to the ICU for delirium and hypotension. So those side effects of refeeding syndrome, like I said, can be pretty severe. And now we'll talk about some interventions for sarcopenia. So trying to increase physical activity, including both resistance training and aerobic exercise. There are some safety concerns around exercise in sarcopenic patients just because, they're probably very deconditioned. So often they will start increasing their physical activity along with a physical therapist and occupational therapist, and then move into exercising more independently. In sarcopenic patients, some dietary changes are also recommended, and these are really just, overall healthy diet recommendations that most people should follow. So complex carbohydrates, which will lead to more adequate fiber intake, taking in healthy unsaturated fats, reducing sodium intake, adequate hydration, and adequate protein intake. So as far as protein goes, the recommended daily allowance, or RDA, for protein in adults is 0.8 grams per kilogram per day, and it's likely insufficient to prevent muscle atrophy in older adults, especially if that patient is already sarcopenic. So protein recommendation for these patients is 1 to 1.5 grams per kilogram per day. Research has also found that protein timing is important in sarcopenic patients. And research has shown that distributing protein throughout the day can be really beneficial because protein, as most of us know, is the building block of muscle. So we want to be consistently feeding our muscles throughout the day to increase that muscle anabolism. So a couple of intervention recommendations for sarcopenic obesity as well. You can prescribe a mild or moderate calorie restriction, but no more than 200 to 750 calories restricted per day is what the research has found should be best for the patient. This is because we don't want them restricting protein. We want them taking in a good amount of protein. Protein does have less calories than fat, so 4 calories per gram of protein compared to 9 calories per gram of fat. So in these patients, it's really focusing on decreasing saturated and trans fat intake and decreasing excess carbohydrate intake. So those simple carbohydrates like added sugar, white flour, things like that, in order to put them in a little bit of a calorie deficit. Then for protein, the recommendation is 1 to 1.2 grams per kilogram per day. And if a patient has other chronic diseases, maybe considering a protein dose of 1.2 to 1.5 grams per kilogram per day. We do need to consider, though, the patients who have renal insufficiency or other kidney diseases. The protein dose may need to be adjusted for those patients. Research has also found that intake of essential amino acids, particularly leucine, can help to promote muscle protein synthesis. So, high essential amino acid intake, along with high dietary fiber intake, may also increase the eugenics of the intestinal microbiota. A couple more interventions for sarcopenic obesity include calcium, making sure that a patient is taking in at least 1,200 milligrams a day of calcium, either in their diet or via supplements. Vitamin D, these patients need at least 1,000 IUs a day. And the Academy of Nutrition and Dietetics specifically recommends vitamin D3. So that can either be from dietary sources like cheese, fortified milk, healthy cereals, fatty fish, or a supplement. Vitamin D3 supplements are pretty common, and there is some research out there to support taking vitamin K2 in addition to the vitamin D3 to aid in the absorption of that D3. But I always tell my patients, make sure you're talking to your doctor about that, especially if they're on like any kind of blood thinner, which vitamin K is a big component of. And then again, increasing physical activity slowly. That may need to start with physical or occupational therapy, just depending on the severity of the sarcopenia, as well as the patient's ability to exercise safely on their own. So, a few takeaways from today's presentation. Malnutrition, sarcopenia, and sarcopenic obesity often exist together, and we know that they can be detrimental to a patient's overall health. They can exist in conjunction with frailty and cachexia, and these patients are typically pretty vulnerable, so we have the opportunity to advocate for them. Nutrition is a key component in the treatment of each of these conditions, along with physical activity. And then just an idea for future research on this topic. I'm a numbers person, like a lot of other dietitians. So I would love to see research done to give more specific recommendations for calorie, protein, and micronutrient needs in these populations, including specific ages, gender, race, and disease states. I think that would be very beneficial for dietitians assessing these patients. So that's it for me.
We have one comment, no questions, but as an RN, we appreciate what dietitians do. So thank you.
Oh, thank you so much. I appreciate you too.
Okay, then I guess with that, then we will close the event for today. Thank you all for being here. Thank you so much, Andrea, for all of your information and suggestions and feedback and tips. We really appreciate it. And we know you spent a lot of time on working on that, and we really appreciate you being here to share that with us. So thank you so much. And everybody else, please watch your emails for an evaluation link. Please complete the evaluation. We do use your feedback when we plan our upcoming program. So please let us know your feedback and suggestions. So thank you all. If you have any questions, contact us at pd@methodistcollege.edu. And thank you again. Have a great afternoon, everybody.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.